Yeah, about I can't do the German yeah that Andre does, but I'll try. But primary pedal access, is it ready for prime time? These are my disclosures. When you think about chronic total occlusion crossings, these are some of the things that you want to think about: center experience, operator experience, anatomical evaluation, and advanced techniques that any CTO center would be utilizing. And when you think about the complexity score or complexity scale, this is the way we communicate with our staff when we're planning these procedures. And typically, critical limb ischemia patients tend to be within the 3 to 4 category, complex, long, calcified lesions. And the chronic total occlusion rates range anywhere from 50 to 60%, depending on which trial you look at and which patient population you're evaluating. And failure rates in crossing CTOs have ranged anywhere from 20 to 40%, at least that's the reported rates. Most operators do not attempt retrograde tibiopedal access unless a traditional attempt to cross a CTO in an antegrade fashion has already been pursued. And the traditional approach provides, in my opinion, a false sense of security and could arguably be harmful in some instances, given that after a failed antegrade attempt, most physicians tend to stop and reschedule the patient for another procedure. And this predisposes the patient to another hospitalization, puncture, potential radiation exposure, and all the other comorbidities. So in 2018, after 3 years, we published the findings of our CoOp trial in Journal of Endovascular Therapy. This work has been built on by Banerjee and colleagues, also with the CoOp classification. Basically, when you do a procedure, this is kind of how the procedure is divided. I mean, there's variations across different operators, but basically you evaluate the CTO, you dedicate about 40% of the time to crossing the CTO, and 50% of the time is dedicated toward revascularization. We had very skilled operators today that I watched. A lot of us know that things do not usually go that straightforward. And I've showed the CoOp classification. The idea behind the CoOp classification is to make it very simple so a lot of our physicians would adopt it. That's the thought process. We don't want to make things complicated so physicians are discouraged from using it. The top of a screen is the groin of a patient. The bottom of a screen is the foot of a patient. So with type 1, it stands to reason that you can cross in an antegrade fashion. You get to the distal CTO cap and you're able to cross. With type 2, you cross in an antegrade fashion. When you get to the distal CTO cap, you're going to get deflected and you might need re-entry. However, it might be easier to approach it in a retrograde fashion and meet in the middle. Type 3 is very challenging because you get deflected proximally, you get deflected distally, and you have to come up with advanced techniques to recanalize those patients. And finally, type 4, which is the reverse of type 1, it's much easier to cross in a retrograde fashion than in an antegrade fashion. Well, when we looked at 142 CTOs, about 115 patients, we looked at the predictors of crossing direction when it comes to the CTO type. And if you're type 1, you're much more likely to cross it in an antegrade fashion. If you're type 4, you're much more likely to cross it in a retrograde fashion. When I say much more likely, that doesn't, that means it's not 100%. We also ran a multivariate analysis looking at which predictors, if they're present in a patient, will predict the need for pedal access. So if you see these things in a patient, you're much more likely to require pedal access. And those were type 2 and 3 CTOs. If you have severe calcification, or if you have lesion lengths or CTO lengths more than 10 centimeters, you're much more likely to require pedal access for those patients. And again, much more likely. It's not black or white. So let me show you an example. This is a typical CTO pattern, the anterior tibial artery, occlusion proximally, reconstitution in the dorsalis pedis artery. And let's see what happens when we try to cross into the distal CTO cap. Typically, a lot of physicians, we like to go across through that occlusion, but in reality what happens is you either get subintimal because you're an experienced operator, or if you're not lucky or maybe don't have the same level of experience, you will actually get outside the vessel. So in this case here, we advanced the wire with the support of a catheter and found out with extravascular ultrasound we're subintimal. So rather than trying to re-enter, which there's nothing wrong with that, you can try to do that based on the physician experience, we decided to obtain retrograde pedal access under ultrasound guidance to the right of a screen. We looped the wire. We were able to tunnel on the left side of a screen, atherectomize, and perform balloon angioplasty. Access to tunneling was about 3 minutes and 45 seconds, just to give you an idea. This is not the gold standard. But versus us attempting to re-enter in an integrated fashion took us about 6 minutes and 36 seconds. And usually that's in my experience, that's a common scenario. How about repeat procedures? This is a perfect example of a case that was attempted before by one of my colleagues. And what you see on the right side of the screen is basically, this is a subintimal dissection with separation between the popliteal and the three tibial vessels. There's a separation and there's an occluded posterior tibial artery. So how are we going to tackle this with a patient that has a pseudoaneurysm in the right groin, a hematoma on the left side, and a limb-threatening ischemia? We access the occluded posterior tibial artery. We access the anterior tibial artery. We cross from the anterior tibial artery into the peroneal artery. But remember, we have to connect the popliteal to the tibial trifurcation. So we access the posterior tibial artery, and finally we were able to cross to the popliteal artery in retrograde fashion. This is how it looks like in real world. There is no groin access for this patient. Now, after that, we were able to also evaluate the SFA and the popliteal arteries. So you have a wire from the anterior tibial artery to the peroneal artery. You have a wire through the posterior tibial artery into the popliteal and the SFA. We were able to evaluate with intravascular ultrasound. And also, we were able to atherectomize and perform balloon angioplasty. This is the right external iliac artery. This is the SFA and the popliteal region. We were able to perform, this is a transtibial intervention, so you can perform a transtibial balloon angioplasty for those patients. This is the final angiogram for the posterior tibial artery. Now, if I was in your place, that's great, but what's going on with beyond the access point of a posterior tibial artery? We can, as you can see here, we went through the anterior tibial artery, through the posterior tibial artery, and advanced the wire all the way to the plantar circulation, removed our pedal sheath, and we were able to perform balloon angioplasty and reestablish the pedal loop for this patient. These are the final angiographic pictures. The posterior tibial artery, you can see the extravasation at the access point within the popliteal artery. This is the three tibial vessels and the popliteal and the trifurcation. And this is a monophasic flow for the dorsalis pedis artery immediately post the removal of a sheath for those patients. So in conclusion, the CTOP trial is the first trial that looked at categorization of CTOs in a simple, easy-to-apply process. Lesion length, calcium content, and CTO types 2 and 3 are the most predictors for requirement of a pedal access. The implications of technical success are significant, exceeding 94% of the cases, and there are potentially time savings and increase in safety profile. Starting with pedal access, and I know I might be in the minority, but if I convince Chris Metzger one day, then I'll be successful. Starting with pedal access may be potentially the standard of care as experience among operators increases. So thank you.